All right, this is a quick audio test for the folks that are online. Please give me a, or somebody just shout out and say we can.
Can hear you.
Be that. Thank you very much. We got some folks showing up, so somebody double mute yourself. Here we go. Sorry. We got folks showing up here live, so we'll give folks about another seconds and we'll get started. Thanks, everybody. Muted. Now you're unmuted. Unmuted. So we'll go unmuted from this point forward until somebody has to push the button for some reason. Good morning, everyone. This is not my meeting, but I'm just going to say I'm Phil. Some of you know me by face. Some of you only know me by picture. And some of you may not even know me at all, or may know me by name on something. I'm your previous fearless leader of this motley crew, and I am super excited just to see you guys' face once again. It's crazy. It's been February 2019 was the last face-to-face meeting, and that wasn't even a coalition meeting. That was actually an exercise planning meeting for our Impact full-scale exercise that on that day we voted to cancel. $50,000 gone. There we go. For we got it back. We got it back in blood though. John and his crew helped us out get through an exercise kind of not as big and as grandiose as we had hoped during that time frame. So we still have all that documentation, and one day we will pull off that exact exercise. But now I think there was a no. I see a block. No, but now that we are back together, and there's an appetite for more face-to-face meetings. And I think from the last coalition call or the previous one, we talked about keeping a battle rhythm of quarterly face-to-face and the monthlies still being online. And these will always have a hybrid option. So whether we're face-to-face or not, we will always have a Teams option available for everyone. So I want to thank everybody and commend everybody for taking. June has been our last couple of weeks have been pretty crazy across the region. So I know things are probably busy at your organizations, but taking the time out to travel here because this is where a lot of things happen that probably can't or don't happen when we're in a hybrid environment. Those side conversations that do get picked up on these microphones and transcribed probably are leading to some great success across the region. So again, we thank you for your time and your organization's time for allowing you guys guys to take the opportunity to get out here for us for the duration. I know some of you guys are coming off of probably the EMS call or whatever else this morning. It's always a long morning, first Wednesday of the month, but I know, thank you.
So we've talked in trauma and EMS. Everybody's going back to hybrid, just like coalition. So starting next meeting, we'll have an in-person option for trauma, EMS, and then coalition.
Awesome. Now, I would be remiss because I know a lot of names, but I don't know everybody's face because we don't see each other as much. And you're going to see less and less of me, and I'm going to give this microphone up here in a minute. But if we could, for those, can we just do a quick run through the room so folks know who we're talking to? I've already started with myself, and I'm going to start on the left side. So we'll start with Mike Gilbert up front, and we'll just kind of weave our way back so folks can put a name with a face.
Mike Gilbert, I'm the EMS system manager for the Southwestern Illinois EMS system here at Memorial.
Cool. Eric Brandmeier, director of EMS and emergency preparedness at Anderson Hospital.
Megan Black, EMS educator at Henderson. Hi, my name is Beth Westman, Illinois Department of Public Health, Regional Emergency Response Coordinator.
Amber Costello, Home Health Services, and Green County Health Department.
Chelsea Beerman, Office Manager at the Green County Health.
Deborah Bever House, County Health Department.
Site Emergency Management at Chester.
Tracy Brown, Director of Emergency Services at West St. Anthony's Malton.
Scott Fossman, Regional Clinical Advisor.
Wendy White, County Health Department.
Chris Lydell, Clinton County Health Department.
Saroja Swagger with STARS.
Shelley Brand Stars.
Libby Brown, Monroe County Health Department.
Tanner Kingery, St. Clair County Health Department.
Regional Management Director. We have a student.
Tyler Lake, Emergency Preparedness Coordinator and Safety Officer at Carlinville Area Hospital.
Eric Perham, EHC Upstairs System Emergency Management Specialist.
Work for duty director, support services and safety part of the hospital.
Richard Frank, I'm sorry, I'm writing this up.
Sean Wilson, Howard,
Jacob Shears, Touche, Regional Hospital Emergency Manager.
And John Nowak, that's our EMS.
And most everybody knows me. I'm Lee French. I'm the emergency manager and healthcare coalition manager here as well.
Well, now those folks got their picture. My picture too. I'm logged in. I didn't realize. Oh yeah. Oh, that's a good thing. That's me. Thank you. Well, let's go back for folks we got online. We got about, let's see, how many folks we got? 14 or actually 11 online. And it looks like we got Heidi Voss here. I'm sorry, we got Heidi Carter, Tara Voss. Who else? Jillian Stowe. Anybody? Is this their first meeting? I see a lot of familiar names. Anyone's first meeting, whether in person or virtually, ever for the coalition? Anyone? Yours? Raise your hand. Hi. All right. So we do have one newbie. Welcome. Everybody is welcome here today. Now, what's really odd is that you're now a member of the coalition if you like it, hate it, or love it. Okay, you're now a member of the coalition. You're within our family. And every member in this coalition that's been around for a long enough time. What? I'm just getting my phone. I'm just getting my phone. I don't know what you're talking about. Every member of this coalition has been around, at least since we've been face to face, presented with at least one coalition coin. And I'm seeing a lot of shaking heads right now.
That's rude.
And some sadness. And you accepted this coin, and you accepted the roles and responsibilities that go along with that coin. Now, the penalty for not having this coin after being presented in a gathering in which there are both food and beverage being offered, what's the penance? One Diet Coke on the rocks with the lime, no chaser. That's my drink of choice, okay? Now, Coke Zero is a suitable substitute. But should this coin hit this table and or the ground, and you do not present it, and you cannot walk within 4 steps of reaching it, you owe me said drink. Now, I'm going to allow this to drop. I'm giving you plenty of time to leave the vicinity, but time is up. And I will see who has either been trained very well. Mike Gilbert has his. Lee French, just like his American Express, never leaves home without it.
Yeah, still like that. He only carries.
Now, I'm working my way backwards because Sean Eisenhower, who is in the office right next to me, always has his coin where?
In my wallet.
And where's your wallet, sir?
It's in my pocket.
Where's the coin? Must present.
It's on my phone.
Oh!
Cause I got a new credit card from corporate that I had to put in my wallet.
And I'm making my way back to my other right hand,
We double check.
Eric Perham.
No. That's.
Oh! Oh my gosh. And this is a 23-year Army veteran, like me, a 23-year Air Force vet, who knows the rules.
That's what you'll get your diet.
And Diet Pepsi is not a suitable sub. Deb, don't ever think about that one. I saw you shake your head, so I presume. I know Georgia has been presented one at least once. And I definitely know Scott has 1 or 2 of these coins, and he's gonna try to make this. This is your mom's coin. This don't count. No, it ain't. Coin is never a coin once presented, and you've taken the oath to keep this and bear with it at all times. So, I'm sorry, switch. Now, I want folks to be honest. How many of you in this room have been presented said coin and have forgot it? This is your opportunity. I come from the Air Force. Our core values were integrity first, service before self, and excellence in all we do.
I'll speak up.
Okay. So 1, 2, 3, 4. That's
Mine is in my personal car.
5, 6. So we're saying that the rest of yous have not been presented a coin. I'm using some who says Utes. I'm thinking of
Joe Pesci.
Joe Pesci. And what's that? My cousin Lee. Such a great movie. Okay. So what I'm going to do is I'm going to go up to my office while someone else is up here speaking, probably during the Kimpack portion or something like that. I'm going to leave and I'm going to come back. I'm going to bring some coins. I will not be bringing coins for those who've been presented said coins. I will be bringing those for the newbies. And expect that in September, I will be greeted with, because I'm gonna bring my coin in September. I will be there. And the reason I will be there is because I'll just say in an order of somewhat good news or anticipatory news. We have made a decision yesterday on offering one of the candidates who applied for my position, offering them the role. And I'm hoping to hear back today or tomorrow that they can accepted the role. So I was praying that we get a decision. They would have been right here to be here today. Unfortunately, not able to do that, but definitely at the next quarterly, and maybe the way BJC moves, maybe not the next meeting, maybe not next month, but the month after. So within the next 60 days, you will have a new me. You've been without me for a while, but you will have a new director of emergency management here at Memorial that will kind of fulfill the role that I fulfilled. I know Sean, Lee, Scott been doing a lot of work to try to carry things on. It does take a lot. So thank you for your time and patience and consideration. So with that said, and all the sad faces who don't have coins here, we're going to continue on with our regularly scheduled programs. Do we have any questions before we get started? Just as a point of note for folks who this is probably maybe one of your first times here, as far as getting in and out of the facility, it's kind of a maze going out. If there is a fire, there are exits both this way and that way. I would say follow me on the way out, but the quickest way to get out is really right through here, right right across. You can go through the cafeteria, down here and out, or that hallway right there on the side. As soon as you go, I take a right and you take an immediate left and it'll take you out. But follow one of us, so all the people that know the building, we'll get you out of here, in time. So, okay. Questions, concerns? No? All right, well,
dirty.
to be expected. I don't know.
I know, I would like to say, I didn't know if you were gonna be here, so, just saying.
Well, Lee could have did it. Is that Lee or Mike? Anybody, any one of you can challenge someone else. It
I
doesn't
usually do it
matter.
at home. I only do it at a farm. That's.
Told you, any place where food and beverage or meeting or gathering place. So we got. Okay. It should be quarterly, but hey, we got a lot of things on the schedule. I guess, am I talking up here all day? Who's talking? I'm gonna, all right, I'll talk for a minute. We're gonna get a sign-in roster. One of the things we forgot in our new thing, so I'll probably leave here during the briefing.
You didn't forget your coin.
Never. We're not forgetting my coin. We'll get everybody by sign-in roster, and what do you call it? We'll capture online, so we know who's here. We got open tasks. Monthly EM resource reporting presented. Corley, do you have any updates to that?
So Javari changed their format again, which broke what I had been using to generate that. So unfortunately, I'm back to square one and working my way through the nightmare that is Javari data. Once I have figured out a way to make a usable report that's quasi-accurate, we'll start doing that again. Unfortunately, this is very much a pain in the rear.
Since I'm not gonna put it all on Dan, but Dan was doing, I mean, this was Dan's life. Dan Lee's life. He did a lot with this, but since he's left, folks just don't. It's just not the same. It's different, right? It's just different. So, and with the changes in Javari, so we've lost access to a few things, columns and things have shifted around. So it hasn't been easy to get the data the way we were once able to get it. So we'll try to get it up there. And I see a note for training requests.
So if you have a request for training, forward it on over to us. We're happy to accommodate, whether it's for decon, whether it's you want to see a course brought into the region. And we'll talk about what we have upcoming because there are a couple of events coming in the very near future. We'll get to those later in the presentation.
Let me back up just 1 second on here. So I know we have, trying to see where I'm at. Am I on here or am I just relaxing?
No, you're
right here.
No, you're under e-business.
Oh, coalition system and development training. Today we will finally, I know Lee's been talking about it, and he's been at my doorstep daily, like, hey, when are we gonna be able to use when we're gonna get away from Member Planet? When are we gonna get away from we will have an opportunity to move away from Member Planet. This will probably be we'll probably go through June. That will be it, and then that will all go away. So my recommendation, everybody who has a Member Planet account, we've taken what we got out of it. We've taken that information and we've crossed it over, and I'll show you a little bit of that later. But I don't know what the account does, so I don't know if you need to delete anything out of there. If you want to, feel free. You can delete because we won't be using it going forward. Okay, so by the end of June, it definitely won't be a used product for us internally. So if there's any information that you have in there that you want out, I would just recommend that you take it out. Just log into your account and not that. Sorry. Let's go around the room. So we'll start with IDPH. And I'll just go right to that. So you can do IDPH and ERC stuff. Any announcements?
End of the grant year, closing out the grant. We're working on deliverables for the new grant. Measles is still around. Fingers crossed is starting to slow down a little bit. CDC, with all their smart heavies and stats people, run the numbers and they say that it's plateauing. So again, fingers crossed it'll go away soon. I think there were a few cases up in Chicago, O'Hare. That's kind of almost a common occurrence because of all the international travel that they have. Missouri's had 2 cases, I believe. So that's what we're watching pretty closely now. Other than that, some events coming up that I'm sure other people will talk about. Our big conference was last month, I can say now, last month. I think we had pretty good turnout. Let me know, I know they sent out a comment evaluation, but if there's anything that you would like to, point out to me, let me know, and I can take that back up to Springfield. Other than that, I'll be doing some training a little bit later this morning, and I think that's it. Unless there are questions.
Questions for Beth? And I know we have the public health department slide here. So, and Beth, unless you have anything else, I'd open it up to any of the public health folks online or here in person. If you have announcements, things you guys do in the county or initiatives, etc. Okay, awesome. St. Louis folks, St. Louis Healthcare Coalition and crew. Updates?
Yes.
Hit the next slide.
We have a lot going on. We got to activate our healthcare multi-agency coordination system with this May 16th tornado event. And that has been very successful. A lot of the initial response was with the long-term care facilities that were either evacuated or without power. Mostly a lot of mass care response. They need food, water, tarps, first aid type of supplies. We're still working with our FQHCs. The latest request was for tarps and ACE images, but the communication, the coordination, all of that has been very successful. And as a lot of response efforts, pretty beautiful to see everybody come together and provide help. We have a cash day coming up. It's June 16th. It is at the St. Charles County Ambulance District, and we will provide food. There will be 3 dumpsters available. For information to come, we'll send out a specific list of the caches that are in the region and where they should be located, and kind of work through that list to determine what is able to be accessible and moved for the 16th. We will require all hands on deck. If you've got 1 or 2 people, make sure that your caches are road ready. So they're able to get to St. Peter's. It's kind of a hike here. Emos is what we're serving, pizza and salad. If you're able to join us, hopefully that will be a little bit of a motivator. It's typically an all-day process, and if you have never been out to SCAD, it's a beautiful facility. So just going out there and getting to see the facilities is pretty cool. All of the work groups that we've had so far it's been a pretty fun day. It is June 16th, which is, hot summer, but the SCAD has the opportunity to have the trailers inside and covered. But the last time we did it, we were outside, so maybe hats, sunscreen, water, things like that. We were going to have our MRSC for June 11th, and due to the tornado response, we have pushed it back to June 20th. We had this big, elaborate, awesome plan worked out for June 11th, and unfortunately, due to just everybody being busy right now, it's going to be scaled down a little bit. However, if you were wanting to participate on June 11th, we still invite you to participate on June 20th. It will probably be, I have to confirm this location, but it will probably be at the BJC Learning Facility in Brentwood. Yes. And if you want to participate, we'd love for you to participate, whether it's as an exercise player or a controller. Everybody is welcome. The exercise will be from 8:30 to 10:30 roughly, with a hot wash directly to follow, and lunch will be provided. We're gonna do like a sandwich box type lunch, if you're interested in attending. We have a lot of projects that are about to kick off. We have an access and functional needs project that is starting this month. We have the healthcare multi-agency coordination system planning project that is to start June, July. We're in the middle of this mass fatality exercise, which I will let Sarojha talk a little bit more about. And I think that's really all I have for the coalition. And then other than STARS updates, we have a new emergency preparedness coordinator, Kelly Brandt. Yeah.
Hi, everyone. I work with Bridget and Shelley at STARS, and I am our liaison to what we call the STARS Mass Fatality Subcommittee. So for those that don't know, the subcommittee is made up of individuals from the medical examiner's offices, coroner's offices, public health, healthcare, really throughout the 8 counties that STARS operates in. And we have a UASI funded, so it's the Urban Area Security Initiative grant program, a project that originally was created and requested funds back in, I want to say 2020, and then it kind of got really heavily impacted by COVID and other delays. Basically, the intent behind this project is to validate a plan that was created even longer ago, around 2016, that looked at a bi-state resource coordination plan in the event of a mass casualty incident. And so the mass fatality subcommittee recognized this plan had been created and then nothing really happened with it, put in a request for the funds to do this exercise series where we were going to try to validate the plan and specifically focus on interagency roles and coordination, and also setting up and running a family assistance center. So all that to say, we've been waiting on this for a number of years, but we're finally able to have it happen this year. It's going to actually occur in 2 phases. Phase 1 of the project, and what is linked on the screen in front of you, is for the first tabletop that is happening on June 17th. That tabletop is pretty much a very introductory one to kind of understand among all of these players what everyone does and how we can, where are the gaps in communication, and just sort of laying a good foundation, because then it's going to be followed by another tabletop in August, and then a phase 2 of the project. We'll see another 2 tabletops, and all culminate in a full scale, probably in spring of next year. Lee and Sean were generous enough to let me show you or loop you all into this project. We originally wanted to make sure that it was open for you all to attend. We very quickly, in the last, I want to say 24 hours, if not 36, net registration. So we have a wait list for this first tabletop on June 17th. If you try to scan that QR code, it will probably tell you that registration is closed, but you can contact our project lead at Haggerty and we can put you on the wait list. And we're going to look and see if we need to adjust that number and see if the location can take in a few more folks. And since that's not an easy thing to get into right now, I would save the date for August 5th. That's when the second tabletop is happening. And I can make sure either via Bridget or just directly Sean and Lee have our information to share further details about this project, because we really want to make sure that we have the representation in Illinois, especially along that. Do we have any more questions? Yeah, it's a long-awaited project that I think is going to address a critical need, and we're really excited to finally get it going. Any questions?
But as far as you said, you need some trash cans over there for the cash assessment, is the goal to just, you're 86ing all of the expires and things like that? Is that the?
Unfortunately, there's a lot of things in our caches that are unusable. Like wipes that don't have any. Any longer. Right.
Awesome, yeah, get rid of the old stuff. Plan on, have you guys already developed a plan on the reestablishment of what will go back into things or not?
It still needs more discussion. But we have definitely all come to the conclusion that what we have been doing isn't working.
It's not sustainable. So you're right. All right, Reamer, Mike.
We've already started picking up and being busy, was it last month that we did the Boy Scout? So, we have a new EMS non-transport in our system, which is the Greater St. Louis Council of Scouting. And they had a huge event that they asked us to come assist with, almost 3,000 scouts on 2,500 acres. So we stepped in, set up a alternate care site for them, brought in medics and EMTs and physicians and nurse practitioners and all sorts of stuff. So the council was very impressed by what their EMS agency could do with the mutual aid support of Reamer. So we brought in 14 providers, 4 UTVs and an alternate care site.
Reamer staying busy.
We got IndyCar coming up next weekend, and then ISP Youth Camp, and then NASCAR,
And then
and then the marathon. And
Watch, rinse, repeat. This is that time of year.
this is our busy time, so.
Good.
And it sounds like that some of our coalition partners from the health department side, did not realize that Remark was even around, right, Lee?
Or what our capability are.
Oh, what we
What we
actually
are.
do, yeah. Yeah. Again, you'll hear me, any coalition meeting as a plug, say, Remark is one of our big successes, here in the region and across the state. I mean, we have one of the only, I would say it's IMERT, then it's our Remark, and then,
We're the only remer.
yeah, we're the only fully functional.
Yeah.
Regional medical emergency response. Then again, like I said, it's IMERT and then it's us. So always looking for support. Want to be a part of the team, please reach out. Eric, anything from the VA? What's going on?
One more slide, sir. There we go.
Got another one after that.
Oh, you actually can see my little extra slide.
Yeah, so on June 11th, we will be executing another full-scale exercise. And you just thought it was safe to go back into the water. We're doing Jaws again. So for those who aren't familiar, we ran this exercise in 2023. We brushed the dust off after a hiatus from COVID. And unfortunately, I somehow won the short straw on another bet and got to do this again because this is supposed to be done in 3 years. So we will be doing this next iteration, and we're adding a couple extra things. So if you want to go to so. So this, for a lot of you that have been on the part of the NDMS planning series, and we had a couple of meetings regarding this particular exercise and what we're expecting. The big things that have transpired is the resource request for both St. Louis and Illinois have been submitted. So there's no big challenges there. The one that I sent through HMAS/SMOG/St. Louis Hospital Coalition, whatever the flavor it is at this moment in time, really covers all of the medical staffing for this event because I requested a medical care task force. That's like 17 personnel. So when the 17 personnel show up, I will just change that resource request and stack 2. And we'll cover all of those. There has been an invitation sent out on March 31st. So if you've gotten that invitation and you want to send it out to other folks, I want to send that to as many people as far as one. The big thing about this, and I just didn't remember the email I sent out yesterday, is PPE. If you're going to work around the aircraft, please bring gloves and make sure you just have stuff that fits you. If not, you're going to have to use federal gloves, and that's a one-size-fits-all, and it never works the way you'd like. So please do that. The other couple of things that I would like to also point out is the air crew wants to stay on the ground for like 4 to 5 hours. So this plane may be there by the time most people will be showing up the setting, which is exactly what I want. This is a working exercise. This is not to test our ability to move very quickly. It's our ability to train folks folks who haven't dealt with this in a very long time to get their skills up. So if you have a lot of new folks that are not familiar with FCC or never really dealt with it back in C-130 or downloaded people and use military style litters and equipment, and this is their opportunity to come because I have a lot of folks from Scott Air Force Base and the National Guard who are subject matter experts in this, and they are all chomping at the bit to train folks. So if you got nursing staffs, EMTs, people who are just wanting to be part of this, show up. This is an opportunity for you to just kind of mill around and look at this. One thing I will say, lunch, we have it set up right now for 130 people. Don't let that number scare you because I can always find more lunches elsewhere. But the big thing is parking. As you can see, the parking hall has to be on that far northeast side. Because Jet Aviation still has normal day-to-day operations to ran. And if I'm not mistaken, there's like 2 sports teams. I think Cardinals is one of them. They got things going on that day, and they're going to fill up that parking lot closer to the south side here. So I'll have some cones out there. We'll be marking everything up, but that starting next Monday, we'll be moving equipment around and we'll be starting to kind of get the box set up. Again, the fire station is the exercise location. And if you go to the next slide, Phil, you can see the timeline, because you'll see that the aircraft arrives between like 9 and 10 o'clock hour. The air crew hasn't really given us information, but what they are trying to do is the air evacuation unit out of Oklahoma that's coming with them. They're picking them up the night before. So that gives us an opportunity for them to be there, to land sooner and be on the ground longer. But we are starting the exercise a little bit earlier. So you can see that we're kind of playing, usually our FCCs kind of start right around that afternoon time frame, like around noon. This one's going to start right around 9. So we're going to bump things up, but we get everybody out a little bit sooner because it is June. So I don't want everybody passing out from heat exhaustion. But the big thing is, folks that really do want to participate are kind of hesitant. This is a great exercise because you're this is your opportunity to do it like 13 times, and if it takes you 14 or 15 times to be comfortable, this is your opportunity to do that many times. So just really being out there and be part of this and see. And I know I invited the MRCs out to the last one to see how they would respond. We are going to bring in some of the SES folks to do some recon. In this particular scenario, we are looking at if you want to mute or unmute, Phil, but we are blowing up Arrowhead Stadium with a dirty bomb. So I say that lightly, but that's, we had to use a real world or a potential real world incident because we had already 2 hurricanes and we never activated NDMS for what happened in Nashville for Hurricane Milton Hood. So we had to think of something else where we could potentially use NDMS, and Arrowhead, because there's a VA that's in close proximity to it, made the most, made a reasonable choice. The other thing is we don't use our decon assets that much, but yeah, we will do your sampling for Stanley Cup and various other sporting events. So we're going to try to look at how can we do your sampling and how can we monitor patients coming from an active scene like that into our region. So it will help us kind of just work out some procedures, see what works, see what doesn't work, and then just take some best practices and work with them. So again, come on out, take a look, see how you guys can play in, and let your staff. So if you have nurses, EMTs, people who are bored, folks that stay at home, volunteers, whatever, push them my way. I'll put them to work for a little bit. And they're up. And don't worry, they got any kind of issues with lifting or any kind of restrictions. I deal with this all day long. Plenty of things for them to keep them busy. So everybody wants to, if they want to participate, I will find a job for them. Thank you. Questions for Eric? That's the one. Listen, please sign in. Please tell your folks. If you show up, please sign in, because not only does it help me with credit, unfortunately, the federal government is stingy. The federal government is stingy. I was trying to come up with some nice coins and all sorts of stuff, and unfortunately, I am hamstrung to all the things that you could possibly ever imagine. Don't put that on that. But I am looking at tokens of appreciation. So if you sign in and you say, I work for this particular facility, it's a way for me to identify who you are so I can figure out how that's going to look. Whether it's an individual thing or maybe something to the system. And EMS does get all that, certificates of appreciation and various other things. So I'm looking at what is within my limits. But yeah, please sign in because it does give me kind of an idea of who showed up, what agencies are being represented.
I swore that Jade and I sat with Lee and Ryan Hurdle, and she was issued a comment. Wasn't she? Was.
Not an hour.
She got it out. I missed it. Hold on. Oh, no, five. You guys know all her money. Look at that. That's dedication. Highly motivated, truly dedicated. She likes it. She loves it. Wants more of it. Oh no, grant update. Oh Jesus, you actually put a slide in here too? Oh my God. Well, as you guys know, that's what I'm saying. Grant year is coming to an end for us. We're probably not gonna be able to execute on it just because of how things have gone this year. But we're gonna have a little bit of fat left over that we're not gonna be able to fully execute on. But that's okay. I know we had a lot of projects that went through with folks, and thank you guys. I know it was tiring to get it done and then kind of feel rushed to get things spent and send us your stuff back, but you guys have been great getting your paperwork back, departments and hospitals. Again, I will always stomp on my EMS folks for not taking advantage of that money out there, but I trust me, with what's going on and the cheapness of federal government, that's Eric Perham's words that I'm putting into the.
Yes.
I got it. Anyway, it's kind of, I know a lot of folks feel like, I've had the question of what's going to come next. We'll end this year fine. Some of you probably went to the summit and you heard one thing or another. If you did read the current legislation or what was proposed and what did pass through Congress, there was a nice line item that went right through HPP program funds. Those HPP, that's $240 million line items that they just deleted in there. Now, Congress and Senate, sounds like, and I talk politics, but it sounds like that bill is dead on arrival that way. Will there be another version of that comes back? I just would find it highly unlikely, just my Phil's personal opinion, that every bit of that money just goes away. I find that highly unlikely, but not impossible, So what does that kind of mean for us as a coalition? So this is the kind of things that I would, I would ask you guys to look through on both sides of the river, because we both get funding the same way. I didn't look at where the UASC one was and where those funds were, but strictly HPP. I feel like we've been very good stewards with those funds year in and year out, at least since I've been here, which I can take account for or responsibility for. Even if the money is gone, that this continues. Most of you know that my salary at one point, not any longer, but my salary, Lee's salary, Sean's salary, part of Scott's salary, comes from those funds. Good thing about it is that when I started doing it, I basically said that we're not going to be 100% funded by that. So just so you know, we use about 25%, or we request about 25% of our salaries to fund the program for manpower, staff, things. So I appreciate it. So from a business standpoint, from Memorial Hospital and or PJC writ large, the impact is, I would say, is somewhat minimal. We do pay for our warehouse that we do have out there, so we have climate control space, because we know storing stuff in trailers outside is a bad thing for extended periods of time. Right, Bridget? Okay. Same up. I mean, we've had stuff that we've stored, but we've learned those lessons. We want to continue to do that. Leadership here thinks that is still a valuable space. The RHCC function that we perform does not go away. There's still going to be a resource hospital. There's still going to be RHCC. The RHCC predates any grant funding, just in the state of Illinois. So how we've been established since the late 70s till today has been a hub and spoke system in which we've always worked together in some way, shape, or form. So Illinois has been kind of built in a coalition, like it or not, hate it or love it. You're a part of an EMS system, you're a mini coalition. And then you're part of an EMS region that just puts all of us together to work together regardless. Now, that EMS region is not the same as the Public Health Emergency Services Response region, which is not the same as Best Public Health region, which is not the same as the Burn Surge region or the pediatric region in the state of Illinois. But I think we can figure it out one way or another. Our bylaws, we don't have bylaws, our governing documents, doesn't always have to be me or the next me or the lead to be the leader of the healthcare coalition. Doesn't. We can go in there and we can say, all right, Jade had her coin, let her do the leading, right? Isn't that what we want to do? But to be a figurehead. Now, does that mean you're the fiduciary and right execution arm? What is a fiduciary when there is no money anymore? Because that's what Memorial is. So you need a real caretaker of the funds. That's the reason why I was put in, or not just why I was put in a position, but why this position exists. Somebody has to manage those funds and be responsible. And be the one that goes to jail if there's appropriation of those funds, right, Jay? Very nice. Very nice. So my vision, Phil's vision, is that we continue just in maybe a slightly different form or slightly different shape with less money. So, but I don't think we end. I don't think we stop. I don't think you stop seeing Lee if money disappears. You're not going to stop seeing Lee. You're not going to stop seeing Sean. You're not going to see whoever my successor whoever's been chosen. You're not going to see that. You're not going to see that. That will still exist. So I want to pause here for us to kind of just talk about it. I mean, I don't say it's an elephant in the room, but it is a thing. So what are your guys' thoughts? Should all the money cease to exist? Georgia can't buy no Deacon supplies with her federal tax paying dollars that she supports, or the other.
I want to challenge you though. I want that Diet Coke back.
I'll give you a Coke.
You and the coin got me, but I do want to challenge you.
Yeah.
You know, you're that smart.
I don't know the exact year.
When we came,
Don't.
I do, because it cost me, I had to get my license then. I used to run without a license. 1979.
That's I knew it was like 70. So
1979. I was forced to get my first EMT license at the state of the national license. I got rid of that years ago.
But yeah, I mean,
It has been around for, and again, like Phil's saying, guys, there was no money. But we all, again, I was young, very young at that time. But still, there was a group of us that still sat and realized that there's only one thing that's going to take care of people injured or anything like that. It really wasn't even a disaster.
Yeah.
It was about just taking care of and connecting hospitals together. Eric, don't you sit there quietly, because I know you're part of that area. Waiting for you to finish. But again, we've done this without money, and we've been very thankful to have money. So, what was Terry's name? Something? No. That's me. That was mid-80s. Anyway, late 80s. I remember who was Terry.
It was Terry and Dodge. But yeah, what John is saying, that
Wasn't called
it was for disaster preparedness.
Okay.
And we existed before it was cool. And we had great participation. So I think the vision is still there. The funds are nice. Don't get me wrong, well, and know this. However, I would have to.
Well, that's really from John, the other. So then, when we do look at operating costs, because like a first receiver decon or reamer team, we have the tent, we have all the equipment that you've ever needed, but we still need to do all the expendables and the perishables, and so that it does come out of the grant funds. Do we start charging? Do we start holding? Like when we start talking in the car and stuff, do we need to look at donations and stuff to replace the things that we have to kind of to look at a funding site so that we can have that backfill for those items, because we know that we won't get that replenishment to keep operations going, because the problem is the next big disaster. Now we need to start, filling out FEMA forms and making sure that all that stuff is getting captured.
Well, the everyday, like the medical supplies, just like any EMS agency gets restocked through the EMS system. The fuel and everything that we use out there is provided by the track. They provide, we don't pay anything for fuel. And they supply all of our food. Really, the only thing that we have is the wear and tear.
That's what I'm getting at. That's the question. I can't reconciliation.
Again, not gonna get into politics. And what is going on and what's being funded or what has previously been funded, it's not gonna go away. I don't care who, I don't care who the president is. This country, being Homeland Security, FBI knows that there has to be a need. Are we gonna see some big cuts? Probably so. Depending on who you have in offices, and that includes Illinois. We have an Illinois governor, because that has changed. Beth, you've been around too, honey.
A lot of governors.
Yeah, and this has changed. I believe myself that money will never, again, when we look at the amounts of money that's been thrown at us, I even remember when there was $400 billion done in St. Louis metropolitan area after 9/11. Hell of a lot of money. There were people but again, I believe that organizations, not as like Remer, people like that, but I believe as big business corporate, they know there's a need. And we've been able to reach out to them before for funding, and a lot of them do as part of policies and regulations in the state of Illinois. I mean, you look at Ameren, you look at chemical plants, they have to put so much money into, and I'm sorry, they haven't, but they have to be a part of the community, do their business within a community. They have to provide funds. We don't take advantage of half of that right now. I think that's it's time. You agree with that, right?
And
Because I know you and I had that conversation about the JUPO and
the
stuff.
other side that I look at with what Eric's talking about with like the wear and tear on the equipment. We have two sides of it. We have wear and tear from when we're using it, but we also see when we don't use it, it dry rots and sits in storage and we throw it away. So which is the worst of two evils? Do we go out and use it and actually trade with it? Or do we let it dry rot in a warehouse or a trailer where it's never gonna get used and we just wasted money? So, it's a double-edged sword on whether we use it for these different events or we let it dry rot somewhere in a warehouse and nobody knows how to use it when it comes time to use it.
We also, just historically, just so you guys know, when I first started, Lee and I's probably first road trip, we went over to Mesh. We went over to Marion County in Indianapolis, and we looked at what they did. They were one of the first established healthcare coalitions that operated. They started with a grant, like a $2.1 million grant, but after that, they're self-sustained through the hospital and special events. So the hospitals, much like what we do with IHA or MHA, pay into a system, and then that system pays back for staffing and event management and everything. So when you go to the National Healthcare Preparedness Coalition Conference, it's put on by MESH. That's what that's led to, and that's been in place probably 12, 13 years now. As far as them as a coalition that's been a standalone 501c3, those options are out there as well. So when we look at, when we're talking to where people invest back into something, where do they invest that money? That's something that I think we would have to make a case for and try to build up, should all funding cease to exist. Again, yes, most of these nonprofit organizations, Big Barns, HSHS, all these, they give a lot of money away. They do give a lot of money away.
Didn't we, when we first got here, we started looking at the whole coalition as a ring. We talked about a 501c3 and we decided not to do it at that time because we didn't feel it was needed, but again, it made.
Yeah, that's what I'm just saying now. So I mean, some of those some of the conversations and ideas and how it works. So I think that you may want to start to just look at, because sustainment is the thing. We can all come together, in hands, and we can do great planning and things like that. But when it comes to doing and executing things, when Remerk has broken their butterfly in the sonogram thing with Bobber in the field, and they need to replace, it costs some dollars. So we still need to have funds. So as I sit on the board at SES, or St. Clair's Special Emergency Services, and we talk about funds routinely. All right, I'm sitting there approving a new set of tires on a truck, but they have a self-sustaining model, but we have to reach out. We reach out for grants, we reach out for donations, we do a whole bunch of stuff just to make sure that part's sustained. And then us as a coalition and your taxpayer dollars have been taking off. SES doesn't have to provide as much for Remerk, even though Remerk falls underneath SES. So we've been kind of supplementing that for the last 8-9 years. So just things to think about going forward. And again, I don't know if you guys, the St. Louis Healthcare Coalition, have had those conversations yet, or what that looks like should all the funding go away, or we have deep cuts. To John's point, we probably could have some major cuts there. That's what I probably see coming back. They use a version of what you have, and then you're not going to eliminate this. Maybe we cut it in half. We go from 240 million to 120 million. Maybe that's what happens. So just stuff to think about. Any other thoughts?
I just have a question, just clarification, when the current grant period is dead June 31st.
Yep. Pasta cuisine, they're dropping the rock, people's elbow on it. Famous.
Previously, I was talking
About a no cost extension. Yeah, it sounds like, there won't be a no cost extension. Shut her off.
It's also important to note that the current HPP manager is retiring on the 31st. So as soon as that grant is done, so is she.
Mhm.
And the new one is yet to have been decided upon. God, no.
If there's a 31st in June, that means she's not retiring. I don't know where to do it.
Whatever.
It's okay. Go ahead, Jordan.
If our items are on back order, should we still send in invoice? Because I ordered
I'm gonna say the answer is more than likely no. So, what is it?
the Avon masks and the Starcom.
I just had to ask a question. I'll ask a question. So, don't panic yet. Don't panic yet.
They don't have a date.
Maybe we can.
Can we suggest that it's almost paid?
I've tried that.
But we won't-
They've gotten more and more stringent over here. It used to be as long as it was paid out by the 30th of June.
And they're getting more that they wanted it again.
Yeah, now they're like, you need to have it in hand before you can ask for reimbursement. So I think in the best case scenario, it'll be early in July. That we may be able to do it by July. So I'll ask the question. Anyone else? Thoughts, concerns, ideas?
Yeah, we already highlighted it. It's broken. And it is what it is. As we work our way, Phil and I are gonna dive deeper into the world of Excel to see if we can extrapolate something useful. But the way Jabari built that EM resource tool, there's a whole lot to be desired. So more to come hopefully next month.
We're talking about just the reporting.
The reporting. So the problem we have is we have hospitals that do not do daily updates, or they do a partial daily update. Just because you updated 5 things out of the 25, even though the rest are still 0, you still have to enter 0. Otherwise, it does not show that as being a full daily update.
Yeah, and you don't necessarily have to enter 0 again. You just need to make sure that the checkbox is checked to say, and it'll still say 0, You just need to make sure you have all the elements or checked before you hit submit. Yeah, because if you just do the 2 things that you know changed from yesterday, it still doesn't count.
And the other problem we have is when we do MCI queries, which we do regularly, we do 6 per quarter, basically, or 6 per
Year.
year. The response rate is not spectacular. And that's concerning because when we have a real world, they're not great. Then we need that data, and the better we get at it, the better we can be. But it's really hard for me to give you a report when I can't easily generate all of it. So
Yeah, and what we will do, just so you know, when there's a real issue, not an exercise issue, we're not going to backfill the information. Real world issue, we're calling a hospital and we can put in the information. We will do that. That way, folks like John or Mike or whoever who's on scene can at least see where we can take folks. We will definitely do that. But during the exercises, yeah, we're not doing it because we want it to work how it's supposed to work. And that should be, in accordance with our plans. And within 15 minutes, when you get requested, we want those numbers updated. So please. And again, I know we stated, we can offer one-on-one training if you have folks. I know we got some stuff set up with Aaron and the good folks at Alton. He wants another D4H class, which we're going to try to do more of for everyone. But if you need any one-on-ones, we can definitely do that.
please make sure your hospitals have the alerts turned on somewhere, somehow. That's the #1 chief complaint is people are, oh, we didn't get the alert. Well, that's not on us. We sent it out. Make sure that somebody's getting the message.
Well, and it can even be set to phones where you get a text message that it went out.
Yeah, Eric got his in Mexico?
He did. Nice. All right, so Sean, any new stuff before we go into before we go into Kimpact stuff?
Is there a slide?
Nope.
SARCOM 21 radio test today for the hospitals. It's the new one. We'll let everybody know that, we put out a request for people to register for our evacuation workshop and patient treatment, which is what it is. So we hosted that last week. Some good discussion. John, Eric, guys, feel free to chime in. We will be meeting again at the end of this month, and we'll continue to grab a kind of regional / hospital evacuation plan that we've been, coordinating, supporting one another, and really leaning on EMS heavily to pull that off. We'll get back to you and give you that big next contact for that next meeting.
SARCOM radios. Have to be reprogrammed by the end of the year. So I have to touch every single SARCOM radio in the region.
Every one of y'all SARCOM radios reprogrammed. So if some of you guys have 1 or 2 handhelds and
1 or 2 mobiles.
mobiles, when we say we're mobile, one that looks like it goes in the car, probably sitting somewhere.
In your ED, more likely.
Yeah, more than likely it's in your emergency department.
But every single one has to be programmed to the new state template by the end of the year. Otherwise, IDPH is going to take it off of their ID list.
Yeah.
So I have to get them all done, which means I have to drive to every hospital. So, but I would like to have them all in one location when I get to the hospital, so I don't have to go find them.
All the secrets ones.
Oh, yeah.
And there's also the chance, it's out for bid right now, we may be getting new mobiles for the hospitals because some of the radios in your ED are probably older than some of the nurses in your ED.
Oh, that's old.
Well,
I said some, not all.
and they're looking at upgrades to our portables to use the new state encryption.
Yeah.
And that's why they're looking at the new mobiles. The mobiles won't take the AES encryption.
Yeah.
So they're looking at getting away from the old encryption and going to new encryption. So they need to get all the radios updated. Our portables, our APX 6000 will work. They just need to have the software added to it. So Chris Cochran's working on getting grant money to cover that. And then that'll be another one where I have to come touch every portable again.
Is that going to be slipped like last time with the computer and?
Yeah, I'm just gonna come in with a computer. I'll have the older radios. I think yours is newer, but I think I'll have to come in and I'll have to do a little bit of work. The portables will be easy, but I can clone them, but the older ones, the radios we use for the EMS our board. We'll have to do, that'll be a little more tricky. It'll take me a little more time. I'll have to custom build each radio.
All right, I hate to drag on the conversation, but. Know where I'm going, Mike. We have hospital talk groups on StarCom. We need to start looking at what St. Louis has been trying to do, and they're finally starting to get somewhere with it.
We're kind of at a standstill with that right now because of Slater.
But no, I mean, for even us here.
I know, but, so the stuff that has happened, so that we now have a talk group that will talk from Starcom to Moslin, which is what St. Louis City uses. They're trying to get Slater to buy onto it, but they're not biting on it. They don't want to pay the cost to it. That would allow us to talk across all three systems without having to have their IDs and keys in our radios.
So, why are you saying that? For some folks who may not be familiar, let folks know what both Starcom, Slater, Moslin actually, what it means.
So they're all trunked radio systems like what we're used to using on Starcom here in Illinois. The state of Missouri has their own trunk system that they have, and then St. Louis County, St. Charles County, and I believe it's Jefferson County and Franklin County has Slater, which is another trunk system that they created. And so we've been working, Corey Hupert, myself, and St. Louis City Fire have been working, and they've got a patch, or it's not a patch, it's a ISSI link that allows us, our talk group, to talk to their talk group, which prevents us from having to have multiple keys when we program a radio.
In layman's terms, we can talk to each other.
Yeah, and it works. And we don't have to have it set up. We don't have to have someone turn it on. It's always up, always running. It is expensive. And I think that's why Slater is not willing to buy onto the ticket. But if they would, it would allow us to be able to have a talk group in Illinois that we could talk to anybody in St. Louis.
What you would call an ailing channel, not an operations channel.
Well, no, so Corey, so the long-term goal of this is to have an entire 16-channel bank of talk groups.
But initially.
Right now, we have a
Single channel.
right now we have two channels that are open. One is they label it as Mercy 800 because it's 800 because it's 700, 800 frequency. And then they have the St. Louis City MCI channel. So we're kind of beta testing it with that, but long-term goal, what they would like to do is have an entire 16-channel zone that all three systems could have in their radio, and we could talk to everybody no matter where we're at.
Which would be great, which would be awesome.
No, again, a couple of weeks ago, when we had pop-up tornadoes and then, St. Louis City get put back up again. St. Louis EMS was able to, again, when the proper channel to be on, but we literally were able to communicate and ask each other for mutual aid within 3 minutes. That tornado in St. Louis. That's huge. And not only that, but every hospital could hear what was being said between you and St. Louis City Fire or EMS. That's what's important. That they gave everybody that St. Louis hospitals just a heads up. That something is going, yes.
So just to clarify, were they listening to that on their own before? They were listening to that on this call, the St. Louis MCI, which is part of the training system.
But the hospitals don't have access to it yet.
Yes, they do.
No, they don't. They don't have Moslin. They only
I'm
have Slater.
telling you, the hospitals I need to talk to, he doesn't verify they understood. That was Barnes, SLU, Children's, Cardinal Glen.
That was on whatever the city set up.
Yeah, that must,
But that's the bridge.
well, no,
That's the bridge.
the city must have a patch into whatever the Slater talk group is, because that's good. Because they're working, because is the Cardinal Glenn that's working on the,
Correct. MCI ratings.
yeah, so,
Some over here.
but yeah, but again,
That should be it right here. But I won't. I'm telling you it works.
because they don't have the most wood rating.
The problem of it was, it's probably where I was trying to get with the whole start of this conversation is nobody in Illinois can hear what was going on with something that's on the.
Well, and
Hospitals.
Hospital lines.
yeah, Corey Hooper has given me permission to, as we're programming radios for EMS, we can put those two channels into their radios. So
If they want to make it, that's what they want.
wide use beta
Yeah,
test.
I mean, that'd be great. I think that's smart.
Oh, no, it's great.
So like,
He's talking about the stars counties here or all of them? You know what I'm saying?
so if we can get it onto Slater, it would cover all the stars counties.
Yeah, but I mean, that's just what, 3?
Let's say. That's eight.
Well, no, I'm telling you, if we can get it on Slater in St. Louis, that would cover every stars county in the stars. Yeah.
But it's just 3.
But I'm saying that we just got 3.
Yep.
More to come as we get that built.
Well, it's progress. It's something. That's
Oh,
some
no,
progress.
it's a big step.
All right.
Sorry.
So we are going to, again, it's over to Beth here in a minute, but I'm gonna give you a little bit of reprieve, Beth, just for a moment. And I have to just ask for a little bit of grace because I'm going to stop sharing this because I have to go to an exercise. So I have to leave here shortly. So I'm gonna skip forward in the agenda and we're gonna talk a little bit about what I was talking about earlier, our move or our transition away from member planning. So I'm gonna stop sharing this for our folks on the slide. Just give me a second and I will start sharing what I'm sharing. So I'll stop presenting. And leave this is in the download, so you'll have to bring it back up when it's time. Let's close that. And I'm gonna share my screen. Share. And I think I should be able to get to the internet. All right. So if somebody that's online, if you can give me a thumbs up that you can see my screen, that would be greatly appreciated. Okay, you can see it. Okay, Scott, thank you.
Hey, Phil, quick announcement. Just making sure everybody knows, we do have refreshments in the back. There's a lot of donuts, there's chips, there's coffee, there's juice. Please take a smoke and go back and get some.
Yeah, please take advantage. All right, so as we've been kind of discussing over the last couple months, we have to move away from Member Planet. So to move away from Member Planet, we looked at a lot of different solutions and things, and we didn't really find something that fit our needs or that we wanted, or things that Lee would probably complain about to me, like, man, I need something to do this, or Mike would maybe say this, or these are the pains that we have with this, or I wish I could do this when we have a class. So smart or stupid move on my behalf, I said, okay, because I do like a lot of just like programming stuff just generally as a hobby, I guess. But back in the day when I was a lot younger, I would do a lot of programming. So databases and stuff. So I built some databases in our department and things that help us do things like when we produce our certificates and things like that when people attend decon class. I had to build a lot of this stuff from scratch and Access. And it was like, well, we can't just do that because you can't use that on the Mac. You can't use that here. Sometimes it's broken on this. So we said, maybe we do something web-wise. So over the last couple of years, I got back into programming myself. So I just built something out that I feel like will help us and basically help replace what we use. So I'm just going to kind of go through it just so you can see it now and give you just a quick overview and tell you where we're going with it. And then we're going to have to host a separate actual training day. Okay, so just an online day where everybody can get in and we'll go through the whole setup of accounts and everything and fully get you squared away so you know what you're using. But I can, at least we're at a point where we have it where it can be demoed. So for those, as we used to, when you would click on the member portal here, we used to have a link that would take you to Member Planet. That now takes you to portal.swillhope.org. So it just takes you to that website. And I'm going to go ahead and sign. I'm going to sign in. I don't know what this is. YouTube dislike button. Okay. Wow. Am I getting? Why am I getting? Oh, these are all of my old. These are all of my old. I don't know what these are. Old plugins or something. Let's see. All right. Let's get rid of that. So I'm just going to go in as an admin right now.
Another quick note, while Phil's doing that, Sam, thank you, for noting that check the batteries on your radios before we do that 3 o'clock test today. That's what it's for all the hospitals.
So once you, don't worry about logging in or anything like that. The site is actually open right now, so you could register, but don't. If you had a Member Planet thing, I'm gonna put this, I have it in, it doesn't allow me registration right now anyway. I'm probably gonna put it in the maintenance mode just for the next week while we go through and finish bug testing it. So I found crazy errors. I was like, oh, that didn't work. I had to go fix it. Sorry. But this is what you'll kind of go into. You'll go to a home page, it's here, and you'll see some quick action buttons down here at the bottom. And that's not really the bottom, but just lower below this is a small screen. And then there are some things in here where it talks about upcoming events, active notifications. We have a notification thing here, surveys, and the like. And whatever your recent activity was within the system, like right down there, you can see it says registered for an active shooter exercise, just kind of tells you some of the things that you've done. The goal of this system is for us to be able to, one, put meetings and everything out on a calendar. So for instance, like you have you'll have a full calendar out here. Matter of fact, I built a coalition meeting. That's for on that. It'll have a calendar up here where you can click on or to give you what it is. Face-to-face meeting link. You can add that to you can add it to your calendar. And it tells you that there's no registration required. So if it was registration required, there'd be a button there for you to register. We'll show you that here in a second. Like it's got all the little details in there, kind of when you get some type of invite. And again, if you were to click that calendar, it would take you to export the event, and depending on your device of choice, whether it's your Google Calendar, Microsoft Outlook, or your Apple Calendar, you can download whatever invitation thing that it works with, or what have you. So a place where you can see the calendar, see all the events. So we'll be able to put like Reaver events that are on here. So when we have that events talk at the very end, all of our calendar events will be on this calendar, kind of going forward. Here's one where I just put in an example one for, what's this for? First Receivers Patient Decon. Basically tells you where it's going to happen. Eric going to host at your place. It's an example. So go ahead and it tells you how many spots you got remaining. I just go ahead and click the register, and then it tells you got 19 spots remaining. As that kind of goes down, that'll send me an email telling me, oh, you're registered, blah, 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 blah. Give you some other details, just like, stuff you're used to. You can add it to your calendar from here, again. And if this fills up, it will offer a waiting list. So you can join the waiting list, and we can, on the back end, monitor that waiting list and get you signed up. So it will send you guys emails, et cetera. And then for us, you can look at this in a list view as well. So this is kind of a more of a list view, so you kind of see whatever going on. So let's take a look at this. This one for Anderson. It shows one person registered, and it kind of shows the details of stuff. Out the way, sorry. Gives you all the details. Probably's got a map in here somewhere. Yep, little map, yada yada. And you can see who's registered for it. Current registrants right here says the admin. That's the account that I'm in right now. And if I wanted to cancel my reservation, I would cancel it. It'd send you an email telling you that you canceled it, etc. And then for us, you can, I'm not gonna get into all the filters, but you can filter these by training, meeting, whatever you wanted to see is there. So we have that. So let's say I registered for that the first receivers patient decon class. Now in turn, once you've passed the class, we would go in and say, here, let's take a quick look, and I'll just so I can show it to you. Oh, I'm sorry. There. So there's 2 events up here. I could go to that course. I would mark my attendees. I would mark me as attended and then provide the certificate. In the end, that will go back to you guys. And once you got that certificate and we give you a certificate, it will email you the certificate to your email directly. And then you can in turn go backwards in here and pull up all your old events that you went to and look at certificates. So what I'm going to do is I'm going to show you that in action by logging in as myself, or just cloaking into it right now. We'll just do this. Okay. All right. So now I'm logged in under my account. I will now, oh, hold on. I can do this right here. So go to the details of that. I'm sorry, you guys can't see it here. Will go to the details of that first receiver event and say, oh man, I want to register for this. Boom, send them, Phil an email, yada, yada, yada. So I'm going to now in turn, you won't be able to see this piece, but I will be able to mark myself as attended. Shows I got 2 folks registered, the admin. So I'm going to mark both of these as attended. One's attended. Yep. And the other person, me, is now attended. I in turn will go here. I'll pull up sign in, generate the attendance reports. I'll take a look. I'll pull this back, sorry. Sign in sheet, and then I will go here to the manage certificates. Oh, I can't because this guy doesn't have admin rights. Let me jump out of here. I don't have admin rights, so I got to uncloak myself for this page. It's an admin moment. Apologies. So now I would in turn generate certificates for both Phil and the admin. Disable the email. Selected. At this point, it would generate the selected certificates. And I can view those certificates here. So you kind of can see the certificate of law was issued. It's got a little certificate number on it. And in your events, I can't get the things on. Oh, I'm going to go back into my dashboard, user management. Open. And now when I go to my events, I can see that I attended the first receivers decon course, just like you'd be on. And if I go to, it says kind of past events, I can go in here and see those certificates. So this is what your kind of library of events attended would look like. So if I pushed this one, it was actually the one for the 23rd, I would in turn see the same certificate. I can download it. Then if you look down here, all these other coalition meetings that I've attended, I haven't published all of the meeting minutes, but for this one, I did do this one as a test. And if I click on that, these are all the minutes for that. So you don't have to worry about someone emailing you a minute or anything like that. Everything will be resided here internally. If you're applying, if you're just somebody who's not a part of coalition and you're attending a decon course, you're Big Barnes, we're going to still ask that you have to create an account. you'll have a student-only account, and you will just have access to the calendar and your My Events page, so you can download your own certificates. Okay? We want to make sure that we're capturing those folks' data and make sure that everything is copacetic, and have a place where you can go back, just like we do at FEMA or any other place, go back in your account, pull your certificates down without having to call someone up and say, hey, Phil or Lee, can you send me that certificate? Can you send me the sign-in roster from that day? You won't have to do that ever again. So there's several other things in here that we'll show you later. But again, not kill your old account at Member Planet, but if there's information you want out of there, go ahead and take it out. We've got the information that we need. The next time that we look back at this, it'll be a little course, so and we'll post it on our YouTube page as well. But the ask is going to be that you create an account with this, and then you start going here to find dates for all of your coalition meetings, what's going on, things you want to put on your calendar, things you want to register for. And there's also going to be a spot where we're going to do all of our survey collection, all of that type of data as well, and several other things that today we don't have time to get into. But so need you to get your account stuff off of there, because Member Planet is going away. So if you loved it for whatever reason, I don't know, it's going away. What? Yeah, this is a lot, man. You can't register or do anything in it today because I just have it as I have it offline for allowing new registrants. But like, your information is in here today. We brought over everything that we could, and what we're going to end up basically doing is we're going to send you an email saying your account is ready to go. Come back in, change your password, and then you can move forward with it. So yeah, as I look in this today, so if I were to go in here now.
Everybody who's already in Member Planet has an account on this website already. Y'all won't necessarily need to create an account. It's already been created.
You'll just be refining your account. We put in your email, etc. So if I look at Georgia, there you go right there. So your information, etc. So any questions regarding that? I mean, that's a good question, Georgia. Any other questions?
Talk about what we might need.
Yeah, I'm just saying, like, some people are like, if I have an account out there anywhere, I want to deactivate it, take all my data out because I don't want anybody accessing it. Because when we're done with it, I don't know what they do with the account. We're gonna turn it off. I don't know if it all deletes, but if you want your information out of it, just go in there and take it out. I know the most folks have in there is pretty much your contact info, stuff like that. Yeah, this has a directory, as you just saw. So, and you can private and display what you want to display. You don't have to show anybody any information. It may show your name, but it won't. If you don't want to show your phone number, it won't show your phone number, etc. So, any other questions, thoughts, concerns about this before we move on? I know we got some time to get through our MCM and ChemPAC stuff. Okay. Oh,
It also does notification, so.
yeah, it's notification as a chat function, a whole bunch of other things. So yeah, you see that? It said, welcome to the coalition meeting. He put a notification there. So you may walk in there and say, oh, be sure to fill out X survey. Go to this page, survey. It'll tell you that, and you got to acknowledge it. So yeah, I mean, that's good. Oh, nice test. We didn't even go through that yet. So I can view that notification. Here's a whole bunch of notifications, a whole bunch of tests in here. Look, this is actually the last one, laugh out loud, because I tested it like 8,000 times, but I just acknowledged that. Welcome to the first person coalition meeting since COVID. So got a lot of little things in here. It's been a nightmare for me to program it. So if you break it, you bought it. That's all I'm saying. All right, I'm gonna stop sharing this, and then we will move on to our MCM briefing and ChemPAC briefing. And every time I say MCM, you know what I think of, Eric? Manuals for court martial. And it's medical countermeasures, but my brain says manuals for court martial every time.
You don't have to do UCMJ.
No UCMJ today. All right, I'll bring slides back up. We're going to turn this back over to Lee and Beth. And yep, what is it? Okay. And just remember, you're on my so yeah, just please. While they're getting set up, sign-in rosters are here. So please print your names and what organization you're representing.
Is it okay? What's that?
Yeah, it's for whatever reason, it took a second last time. So we're gonna mute here for a second while things load up.
And the rest of your slides follow.
Better.
Disclaimer.
Right?
This is mine now. In your, yeah, so when you go next, it'll go into your stuff.
Is it this one?
Yes, okay. Here, you got to put that on.
There it goes.
All right. All right, don't feel, you guys have to sit there if you need to get up and use the restroom or get some more coffee, or hopefully I won't put you to sleep. This is something that we've done annually. It's a grant requirement. It's in the public health grant as a deliverable. I think it's also in that grant, so you can check that box. I have changed some of it, and Lee has put together the Chempact side of it. Greg Atterbury used to do this, so we were kind of looking, oh, and that reminds me, I talked to him last month. He's doing well. He said to tell everybody hi. And I meant to get, like, I'm thinking of picture with a frame and have everybody sign it. So somebody remind me when we have our next in-person. I'd like to do that for him. Okay. I also, before I forget, for those, the health departments know this, I'm not sure if the hospitals know. For those of you who use SEMP, it's going away, official. Yeah.
Darn.
Is it wrong to say I'll think when I see it?
Yeah.
It's still there. It will be there until the end of this coming up grant year. My suggestion is pull everything out that you want by the end of the year, by Christmas. So yes, it's official. We have it in writing. I've been telling everybody, so I think everybody knows how I feel about it. Okay, Chempact. So Chempact is a part of the Strategic National Stockpile. And you can read this. It provides nerve agent antidotes in case of an emergency. I've got a couple of slides about this a little further on. But as you all know, medical people, if there's a nerve agent, people are exposed to it. It doesn't take long for illness and fatalities to start, depending on concentration. So there isn't time to call the CDC and say, hey, we need some antidote. The CDC realizes that, so they pre-placed all of these caches of all over the country. Some of them are in firehouses here in Illinois. They're stored in hospitals. I believe they are also stored in hospitals over in Missouri. Again, a little further on, we'll talk about how that process works. And I think Lee's going to talk about specifically the plan here in the region. And strategic national stockpile is, it all started with anthrax in 2001, was it? Actually, the stockpile started in 1999. We realized that if something were to happen, we did not have, as a nation, enough medicine to treat everyone in a timely fashion. So the US government then started a stockpile program, and that's what this refers to as SNS, Strategic National Stockpile. Okay, the old presentation that I used to give was one that Dr. Carla Little put together, and it was really getting outdated. I hated even using it back 6 years ago. So us ERCs in the state, me and I think there's 7 of us, got together and put this together as a training. I'm going to give credit. Most of the work was done by the Chicago ERCs, my counterparts up there. The rest of us had some issues, but I'm going to give them credit for doing most of the work on this. Okay, we're going to talk about what is SNS. I'm going to kind of skip through this quickly. How many of you do not know what SNS is, or medical countermeasures? All right, so I can go through even more quickly. This is a picture of an unknown location. CDC won't even tell us where this stockpile is located. And it's not just in one place, it's in several places throughout the country. It's just a lot of stuff. It's part of the federal medical response infrastructure and can supplement medical countermeasures. There's all kinds of stuff in there, and they are ready to go 24/7. I already talked about this. This is a little bit of history. The things that they concentrate on are terrorism agents like botulism, anthrax, smallpox, plague, viral hemorrhagic fevers, and tularemia. Those are the diseases or the agents that are considered by the FBI to be most likely used in a terrorist event. And for public health, these are things that we don't routinely treat or see in the medical system. There is enough supplies for everyone in the United States. Again, that's what CDC is telling us. Once there is an event and you would ask for medical countermeasures to the state would then ask for the CDC, and then they would start the ball rolling. Sometimes it has to be very quick. We'll talk about the 48-hour mission. Okay, so if it's an anthrax event, at 48 hours, people who have been exposed to anthrax, the curve goes up. Fatalities start at 48 hours. That's what we want to avoid, obviously. So the timeline is, once CDC is notified, they have 12 hours to get the stuff to us, to the state. We as the state then have 12 hours to get the stuff to you. That gives you 12 hours to trophy the population. Again, if it's anthrax, it's a quick process. If you're not sure what it is, people are going down, we see signs and symptoms, we might see something in essence, but we're not sure. We can call and ask for the 12-hour push package. It's not enough for the entire jurisdiction, but it's a little bit of everything. So if you don't know if it's anthrax, you don't know if it's smallpox, you don't know if it's tularemia, it's a little bit of everything to help deal with that. to give you some time to figure out what it is. Managed inventory is when you do know what it is. And you say, we've got definitely confirmed smallpox. Then the CDC will put together the stuff you need to remedy smallpox and push that out to the states, and then subsequently we will push it out to the locals. When I say locals, I mean some of it will go to local health departments, some of it will go to hospitals. ChemPack is the other side of the strategic national stockpile that, like I already said, deals with insecticides, pesticides, the kinds of things that happen quickly. And again, there are locations here in the region that stock those. We have a good relationship with Missouri. When we've had big events on either side of the river, we have had a gentle person's agreement to share the SNS if necessary. Not only crossing state lines, but that crosses FEMA regions too. The one that I was first involved in was one of the presidential debates, the vice presidential debates that they had over in St. Louis. High profile event. If they needed if they needed some ChemPack, then we had plans to do them. More than 90% of the U.S. population is within 1 hour of a ChemPack location. Just so you can know, and we'll talk about our plan. Oh, I forgot to remove the question marks. In Illinois, I think there are 32 sites outside of Chicago where ChemPack is stored. Are we allowed to say now where it's stored here?
Technically, it's FOU, but yeah. I'll tell you, you're really close to
God, it's not a snake.
it.
One of those things you don't want to go home and, talk about when you go to the bar tonight, so the guy sitting next to you at the bar. Yeah, we don't want the bad guys to know. And then Chicago, we'll just skip over. Something else that's in the stockpile is a federal medical station. This becomes important during hurricanes. They seem to like to use these. Big earthquake, if it would happen here, this might be something that we would request. Notice here it says the federal medical station can support healthcare systems anywhere in the United States. It's all this stuff, the beds, the supplies, anything you may need, but it does not come with staff. I want to make that very clear. That's something that if we need this, we would have to supply the staff. PPE, I'm going to go over this one quick. We did use the Strategic National Stockpile for PPE during COVID. Illinois has a small cache that we're basically starting from scratch. I think most of it is either way outdated, not useful. So at the state level, we're kind of redoing how we do our state cache, how we would receive this and then send it back out again. So again, we did this during COVID. Ventilators, again, Strategic National Stockpile has a lot of ventilators. And we did request those, and we did use those during COVID for the hospital folks. Sustaining the stockpile, and there are people at CDC that this is what they do all the time. They work with the FDA on the medicine, on the drugs to make sure that it doesn't go past its shelf life. Temperature control, just like all your pharmacy people do all the time. That's what they do, only in a huge quantity. Quality assurance, inventory, environmental conditions, ensuring the ability to transport. I will say most of the items, I don't know if they have a picture in here. I think it was the first picture, are stored in containers that look like they could just roll onto an airplane. I'll put it that way. But then they also have these kinds of situations. They like to put the stuff on pallets. That's why when I go out to the health departments to see where they're going to receive and store their stuff, we try to make sure that you can move pallets. This is an example of when the Strategic National Stockpile was requested and used. 2001 was the first one, of course, the NPRAX after 9/11. A lot of hurricanes you see here. H1N1 we actually did activate here in Illinois. We activated our plan and we sent out supplies to the local health departments and the hospitals for those of you who were around then. Flooding, hurricane, Ebola, 2014 and 2015. And some of you got some supplies during the Ebola response. Botulism outbreak, I'm not familiar with that one. I don't know where that was. Zika virus, hurricane, and then of course the big COVID. Mpox, we did use the Strategic National Stockpile. In fact, there were some health departments in the region that did get vaccine for Mpox. And then the latest one, H5N1. I think we can also add, again, we some of the health departments received PPE supplies for dairy workers. Just again, in the region, just in case we have some a bunch of cases. Oh, and there's those containers that are shaped just so they can roll onto an airplane. I'm not saying that the stuff comes by airplane, but this is what they gave us. So how do we know when we can request? You got a snake bite in the ER. You cannot request Strategic National Stockpile. It's for big stuff. When the normal system gets overwhelmed. When it's something that we normally don't deal with, that you probably don't have vaccine in your pharmacy. Smallpox is a big one. We haven't had a smallpox case in the world for decades. But there are at least 2 labs that do have active smallpox virus. So there's always that possibility. That would be an example of definitely calling out the Strategic National Stockpile. Nobody's got vaccine except the CDC. And it's kind of a mutual decision between clinical, laboratory, epi, looking and saying, yeah, we think this is something. One of the things that we look at for BioWatch, it's one of the discussions that we have if we think there's an event, is do we want to request the SMS? ESFA request process, and I know a lot of you have seen this multiple times and it gets tweaked a little bit now and then, and you probably can't read it here. I was told when I was in college, don't ever apologize for someone not being able to see your presentation. You shouldn't apologize because you should make it big enough that they can see the presentation. So I'm breaking my professor's rule and apologize that you can't see this. We're sending these slides out, are we? Yeah. Okay, so yeah, you can you can,
Just a few things.
yeah, we have trouble. emailing. Okay. Requesting SNS. It's a formal process. If you exhaust your resources through normal chain, coordinate with your local EMA. The EMA sends the request to the state SEOC. And the SEOC then informs the IDPH liaison, hey, we've got something going on down in the Edwardsville region and requesting, ventilators. The hospital request needs to be coordinated with the local health department. You guys did this during COVID. This should be a refresher for those of you who went through that. Your normal request process would be exhausted. You're not going to probably call and get 50 ventilators from your ventilator company. That's not something that would probably be available, I would assume. You would need to ask your local hospital system, RHCC, the region. RHCC has a lot of stuff to available, like you were talking about, a whole warehouse of stuff. If that is not working, if that's not available, then you ask the local health department, who then would ask the local EMA, who then would send it back to the state. Now it's kind of convoluted. The reason it has to go through emergency management is for funding. By law, anything that is requested has to be approved by EMA. I used to work for EMA in previous life, and I had been in the SEOC where payment was rejected because they didn't follow this process. So make sure that you go through your local EMA. Oftentimes, this is formality. You make the calls and it gets to the SEOC in 30 minutes. But you still have to follow up with the people. The request is made to the CDC, then they consider if it should be fulfilled or not. Generally, it's not a problem unless there are really limited resources like there were during COVID. But just to let you know, it's not a done deal just because you asked them. Probably, but not 100%. Receiving SNS. And I think I talked about this a little bit. The federal SNS warehouse sends it to the state. The state in Illinois, we use a hub and spoke system. We send it to, we get it in our RSS, send it out to regional sites. And then from there, it goes to the hospitals and the health departments. The plan calls for, and I'll tell you, but again, don't epilural. You may get it through a delivery system, like we do a lot during. You may just get it from UPS or FedEx. You may get it by courier. You also may get it via a IDOT orange truck. We have multiple ways to get the stuff to you depending on how time sensitive and how temperature controlled it has to be and how much. So once you guys get it, now you get to stand up and do your thing. Pod point of dispensing, somebody asked me that just a few weeks ago, one of the newbies of the health departments. So point of dispensing means that that's a place where you would dispense to the patients or the citizens or whoever needs the medicine or the stuff. There are different ways to do this, especially if it's the anthrax 48-hour mission. We're talking, you gotta be quick. So there are different methods that we would use to get the stuff out quick. Head of household dispensing, for example, if a person comes and they've got 5 kids and a wife, we're not gonna make all of them come to pick up. We would just give all the medicine to whoever shows up for the family and say, okay, here, you can give these pills to your family. Yeah. And this is a little bit different than what we do down here, express and assisted. So in the region, along with the health departments over in St. Louis, the entire MSA region, we have a plan where we have an online system where citizens can go in, log in, fill out the paperwork, give print, create a barcode, take that paper to the dispensing site, to the pod, where it's just like when you go to the ballgame. They'll scan your, instead of scanning your ticket, they'll scan your paper. It creates the barcode that goes on the medicine so that the nurses know who's getting what. They put it on paper. It's all automated, and it makes things go really, really quickly. Drive-through pods. I think just about every health department did that during COVID. I know there were some. I think there were some in the hospitals too, maybe in the parking lots, if I recall. Closed pod is when we would give the medicine to long-term care facility. The hospital's already got theirs, to a manufacturing facility that has their own medical staff. We just give them enough for all of their employees and all of their family, and they take care of dispensing to them. That helps us a lot. We don't have to have all the teachers coming through the line. We just give the medicine to the school district and their school nurse that takes care of their staff, sometimes also students. St. Louis County at one time had 50% of their population enrolled in closed pods. The population of St. Louis County is 1 million people. So trying to pro-feed 1 million people in 24 hours would be quite the challenge. So that was a priority for them. And they did, I don't know what their numbers are now, this was pre-COVID. So that's what the health departments do, is really encourage closed pods. Hospitals are pretty much their own closed pod, and we did that during COVID. Homebound delivery. I hate to say it, but generally, the people who are homebound are not high on the priority list, not because they're not important, but because they're not out and about being exposed to whatever it is that's out there. But there are plans to, especially in home health, to go out, and when they do their work in the really give so review your plans. Something's supposed to be updated once a year. Train and exercise, which did the big exercise during COVID, but we're working around doing it again, updating it. CDC training has a lot of online courses if you are interested. And there's my contact. And the vacant is the Greg Atterbury. Back. Did you want to do this? You want me to keep going?
It's up to you.
I think that this is what's in the hospital. This is what it looks like. We talked about this. There are 2 types of ChemPath containers. One is for EMS and one is for the hospital. EMS is designed to go out into the field wherever the incident may be. The hospitals are you know, of course, for the hospital. There's an event, people are going to come to the hospital. EMS is going to go out to the hospitals, or out to the event. So it's kind of both. You know what, I'm going to let you do this because I don't know some of these
Yeah, of course.
medical things.
All right, so the two kits, you have an EMS kit, which is predominantly going to be auto injectors, like think EpiPens, right? Super simple, rapid, easy to administer. There's 454 doses in a cage, each of those rolling cages. So that's 454 for EMS. It's 1,000 for the hospital, but the hospital does not get but just a very few of the auto injectors. Everything else is in multi-dose vials, but they give you everything you need to be able to administer up to 1,000 doses in totality. So syringes, fluid, everything. When we talk about the roles and responsibilities, so CDC owns all this stuff. It exists under a program called SLEP, or Shelf Life Extension Program. This is how they can ensure that this stuff, even though the expiration date might have been 5 years ago, that they say it's still good because they test from each lot every year to see its efficacy. The state of Illinois is responsible for distributing those assets across the state. Like what was said earlier, they're kept in hospitals here. They did used to be in firehouses at one point. We had some through Mavis back in the day, but that's all been since consolidated for care and maintenance. When we talk again about the roles, responsibilities, coordination with RHCC, we will work with the hospitals that have it to ensure that they're getting whatever they need from us for that. We'll also coordinate, like, again, if we're going to do some big event, president's coming to town and they want to worry about forward deploying or better positioning, we can assist with that. We do develop the KIMPAC plan, and we'll talk about our KIMPAC annex that we have here in a minute. And then we go through training. We actually teach this as a part of the DCON program. So anyone that takes DCON learns how to use an auto injector. You'll learn how to use a duodope. You're not doing multi-dose vials wearing a chem suit with 3 pairs of gloves and a mask. You can try, and it will be quite entertaining for everyone who's not affected. But cash sites. So easiest way to think of this program is, I'll be honest, this program is kind of flawed. And I can go on a soapbox and explain why, but the long and short of it is, unless the incident happens here, the chemicals that we need to respond to the incident are too far from where it happened. Because it's in a building, in a room that's locked, in a cage, like an actual fenced-in cage that's locked and alarmed. And then inside of that, inside of the 2 kits that you saw earlier, they both have their own independent alarm that rings all the way to the CDC warning center, or their command center down in Atlanta. Every time we open that, we have to call them, let them know, or they call us going, hey, somebody just broke into your crap. So we did a drill with this a couple years ago. It took forever to get the KIMPAC broke down and sent out to the test sites, and we only sent simulated stuff. I think it was Skittles and M&Ms. But
We said Jolly Ranchers.
oh, it was Jolly Ranchers on yours, okay. But the challenge we faced was, there's 454 doses in that cage for EMS, right? If you call me, John calls me and says, hey, I'm at Eckerd's, I've got 65 people showing signs of exposure to the organophosphate. Am I sending all 454 doses out there? Well, what's my formula to break it down to figure out how much I actually sent? It doesn't exist. We're still trying to come up with a valid thought process on this. And the same thing for a hospital. I have 1,000 total doses in that. Am I going to send them all to, let's say, Carlinville? No. I'm going to send them what they need to deal with that, and then I'm going to disperse across the other hospitals that might absorb from it, right? Again, there is no actual top-down approach to that. We have to wing it almost every time we think about it. List of contacts. It's important that we have valid contacts for your pharmacists, because that's who ultimately would be responsible for signing this. And this is your annual training requirement. So EMS, they're supposed to have protocols. I leave it to Mike and Eric and Rachel and all the other coordinators to come up with that stuff. It's an auto injector. I mean, it's so simple the Marines can do it. Any Marines in the room apologize, but it's true. You know, it is what it is. When we talk about the actual KIMPAC, how it's supposed to get to the scene, the state plan says you're going to put it in a squad car and they're going to take it. The squad car says, I ain't going out of my venue. I don't have enough cars on the street as it is. Our stance is any vehicle with lights and a siren, chuck it in the back and take it to the scene. Get it there as fast as you can. Steal that ambulance that's parked in your ambulance bay and off it goes. The idea though is we work together, we train together. So activation, and we'll go into what our region plan says here in a minute, but the state plan says you got to have 50 casualties or more, 50 or more people that are affected or exposed showing symptoms. EMS is going to determine that. Anybody know, aside from a couple of people I know don't answer, anyone know the signs and symptoms of organophosphate? What are you looking for on your patient? We don't do enough on that when we talk to EMS. There's a lot of misconception about that. It's something that we're trying to work on. We actually have a training program that's built. I have a PowerPoint deck that we're finalizing. It's actually upstairs with Jeff right now. Once he finishes the final, hey, I'm an instructor tweaks, then we'll send it out and that'll be available for all of the region to use to train EMS as well as hospital staff.
And well, and just to mention on top of that for EMS partners is that IDPH has put out the recommendation that that be every 2 years that we do training on ChemPack. So I know for us in our system, we put that into our CE requirements.
And it to me, it's just one of those, it's an easy, low hanging fruit thing. The communications, this one's a little bigger. You can almost read it. Event kicks off. This is the state's version. I'll show you ours in a second. ChemPack Hospital gets, whoever gets overwhelmed, blah, 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 follow the path. Ours is a little bit easier, it's at least more colorful, we'll say that. ChemPack, where it's, oh shoot, well now you know where they're stored. Know who your hospital is. It stores your ChemPack. For my EMS folks, you're going to call your resource hospital. Your resource hospital, if they are not a ChemPack facility, they are going to call the ChemPack facility as well as the RHCC. We will then reach out to the SEOC and to the FIOC and to all these other acronyms, basically all of the federal and state level folks to say, bad juju, things aren't good here. But you'll notice when you look at some of these, Harlanville's not on this list.
Oh, we get ours on a quick bill.
And Fayette County's not on this list.
Big bag of nurses.
Yes. And so knowing who you need to go to is kind of a critical component.
The problem with us though is they will not release us unless there's an actual emergency, so we just have straight vials of atropine, that's all we get.
Hold that thought.
Is this
So-
a gallon jug?
So here's the problem, right? So here's the problem. When you read the region plan, and I'll show you in a second, there's actually a thing in the region annex here. Every hospital is expected to maintain a minimum of 5 moderately exposed patients worth of not just atropine, but pralidoxime. Because you can give them all the atropine in the world, you are not reversing the actual phosphorylation of acetylcholine and all of this fun shit that's going to cause them. We have to have the 2-PAM, proto-PAM, whatever you want to call it. You have to have it or the problem isn't ever going to be resolved. And your atropine, it better be in gallon jugs because you're going to go through everything you have in the house for an actual exposure. The way our stuff is read, just like the rest of our EOP, we follow the 5-tier program, right? So this is just giving you the EOP highlight. Plan activation. Bad thing happens. Little light bulb comes on going, oh, I should probably call somebody like right now. What tier is this? Oh, this is a 1, 2, 3, 4, 5, and then it gets broadcast out to everybody. Short, sweet, to the point, right? An alert is a number 5. It's the, hey, there's something going on. It's not got bad yet. There's a possibility. 4, we got a minor impact, or maybe we're staging equipment. Maybe we're doing things to that effect. Moderate, now we have a problem affecting 1 hospital or maybe 2 small hospitals that are close proximity to each other from the same incident. Major and then severe. As things escalate, worse things happen. But when we start talking like ChemPack, now we're getting into severe because now we're busting into antidotes and time-sensitive things. What you see, these are the different forms that we use within the region. The one that you want to know for ChemPack is there's actually a ChemPack checklist. I highly encourage all of the hospitals to keep that next to your ambulance radio. It tells you exactly what you need to do when they call in and say, this is happening. It gives you questions and answers. You ask the crew the question, write down the answer. It will help you figure out what your next step is. I wish I could make it bigger for you, but this is where it's at. It walks through ED actions. What should the ED be doing? It talks about what should pharmacy be doing? What should your security be doing? Because they're going to be involved in this. They're going to probably have to unlock a door to get to a cage, to get the material. It gives signs and symptoms. So we teach two different ways of looking at this. I have what I call the simple way, and then I have the healthcare way. Simple way is sludge them. Short, really simple, easy, anybody can do it. For my clinical providers who are actually going to be giving medical aid and doing all the fun stuff, I prefer the dumbbells because it gets into the specifics of the symptoms. And we'll talk about all that stuff in that upcoming training. Down below, it has your treatment algorithm. I said earlier, you're expected to maintain 5 patients worth for 5 moderately exposed patients. What's a moderately exposed patient? That's a great question that we don't have an ideal answer to because every source you look at looks at it differently. To me, is when you start to see the nicotinic reaction, you start to see the heart rate and blood pressure, you start to see the respiratory issues. Highlights again, we've identified major event, maybe we're moving stuff to cooperate with our St. Louis partners. Now we have people who are unexposed, exposed and unprotected, so on and so forth. This is our plan. Bill made this, that's why it's all colorful, because he's Mr. Artsy Fartsy. But happens, hospital or EMS. What's each person doing? How's it happening? What's your flow across? This is also in that plan. But it breaks down everything. One of the big things we have to do with this, like any other federally provided asset, is a chain of custody form. We have to know who took it, what they took, where it went, all this fun stuff, what the disposition was for any unused or wasted materials. So that basically is the short and sweet. The biggest thing is, again, I can't reiterate it enough. Your ED should have enough for 5 patients. Hey, 10 duodose is enough for 5 moderately exposed patients. A case of 30 duodose is, what was it, $3,500? Somewhere else. I mean, we spend a lot more than that on stupider things in healthcare. So that's it for Kimpact questions. The annex is available on the shared, on the Box drive. You can download it from the Coalition's Box website. So the new business, as we said, hey, we're moving over. It's actually happening. It's a world relief for me. Training and demonstration and a fall decon class schedule. So since Phil already went through that, we do have stuff, right? We've talked about it. We don't know what's going to happen with funding in the future. We have stuff now that we need to get out and actually use and train people on. We were supposed to take the truck up and take it to Anderson with the decon trailer a month or 2 ago. Truck broke down. Truck's being fixed. We're going to do another show and tell up at Anderson on the 12th of August. And we have all these other items here that we're kind of looking for folks that are interested. Now we've got a portable morgue. We also have an O2 trailer. We can actually fill O2 cylinders in the field. We can fill the cylinders that fill the cylinders in the field with the oxygen generating system that we have. And then on June 12th, if anyone's interested in learning how to set up the actual field hospitals, we'll be setting up tents and medical treatment site at the raceway for the IndyCar race. The REMERT team provides the medical coverage over that weekend, and we use the Western Shelter system for that.
Well, we're actually going to set up 2 that we're going to set up the Western and the new
And the
one.
DLX, yeah. And we do actually, as of this morning, I got confirmation, our other tents will be arriving on or about June 23rd. So we'll actually have a lot of options available. The other thing we've been talking about, this has come up with EMS. It actually came up on this morning's call. EID, right? We don't hear a lot about Ebola, but there's other emerging infectious diseases. Not all are hemorrhagic fevers. There's all kinds of different things we might be worried about. The question was, do we need to establish a work group? And if so, is there an organization that would like to share that? I can tell you right now that Sean and I both are pretty much bandwidth occupied. We're task saturated most of the time. we're happy to help, but we don't have the time to actually run this. So if someone else wants to run it, we will provide the support for it. We have a partnership with our folks at Barnes Jewish because they are an assessment center for Ebola. They have developed training for EMS as well. They are in the process of coming up with a training program for our smaller hospitals that are more outlying. Because we recognize if you get somebody, you're going to sit on them for a while until we can get them somewhere else. The state plan says go to Chicago. That's the closest assessment or treatment center. And for EMS, that's at least 6 hours in a plastic suit and a respirator in the back of a truck with somebody who's got something that you're petrified of. So, prior preparation prevents piss poor performance. And we're going to, try to address that.
Wait, and then are they still using people? Like I know when we did this the last time, they were still using people region to go to Chicago. And if you're in Missouri, you have to go to Nebraska or whatever, and so plan the solution.
So the plan states we will go to a Illinois Assessment or Treatment Center. That is what the plan states. As anyone that knows who Mr. Murphy is, no plan survives first contact. So, yeah, I'll just leave it at that. But again, not everything's going to be Ebola, right? It could be any number of different issues or ailments. So do we need to have a work group? If so, again, if you're interested, please let us know. This is something I think we really do have a need for. I would imagine public health would agree that more discussion around measles and some of the other fun things is probably worthwhile. Upcoming events, Sean, you want to do it?
We've talked about them all pretty much.
All right, so, the 2 TEACS courses, you can register for those on the TEACS website. They're cybersecurity related, but they are excellent courses. And remember, one of our big grant projects for this, or grant requirements, is an emphasis on cyber for the next couple of years. This will help get you and your staff ready for the inevitabilities, because they really do some scary stuff in the training. They make you aware of what the risks really are. Open floor, questions, concerns, comments, anything. I know we're 18 minutes over, so I apologize, but I think being the first meeting back in person, there's a lot of really good discussion that would not have happened via Teams.
Elite Team's got a question.
Can you read it?
Has her hand up.
Okay.
Thank you. She's here.
She just needs to unmute.
Hi, this is Tina. Can you hear me?
Go ahead, Tina.
Can you hear me now?
I can hear you, Tina.
I think Phil forgot to unmute it.
No, it's not. It's unmuted. Tina, can you hear us?
Yes, can you hear me?
Yes, ma'am. Gotcha.
So the coalition conference phone line that we used to use, is that the same phone line? Is that still a working number? Did you hear me?